I believe so. I see it on my screen here.
Great. Terrific. Thank you, Ray, and good afternoon, everyone. Thank you for giving me the opportunity to share with you a little bit of our experience with AccuBoost. We refer to the process of treatment as non-invasive image-guided breast brachytherapy. The commercial name is AccuBoost. And we have been really very impressed with the system over the years. We began working with it over 10 years ago. And the features, obviously, a non-invasive form of breast brachytherapy that entails breast immobilization with breast compression and a collimated photon a beam generated by iridium-192 with a sharply delineated a beam that results, that I'll get into the dosimetry of in a second, but we see that as a big advantage. But the biggest advantage of the system that we have found is the fact that it's a mammographic image-guided platform. I think this is very unique to AccuBoost and really is, in my view, a very significant advance in the treatment of breast cancer. So the system really is pretty straightforward. Relies on mammographic determination of the target, looking at postoperative changes or marking clips if they're left behind. And then a specialized grid is in the mammographic image in which the target selection is guided, and then the placement of a variety of different applicators in terms of both shapes and sizes. And as you can see in this image, the applicator is actually placed right on the mammographic plate. The HDR source travels in a circular fashion through the applicator, resulting in this very sharply collimated radiation beam. And this process is repeated just as a mammogram is in orthogonal positions. So breast compression is performed, an image is taken, the target is selected, the applicator position is chosen, the applicator is positioned, and then treatment is delivered in the compressed position. And this process is repeated in, as I said, in orthogonal views with medial lateral and cranial caudad to result in a cumulative dose distribution at target depth in the breast. Now, in our experience, when we're doing boost irradiation on any given day, we will typically treat just one axis. But if we're using AccuBoost for APBI, we'll treat both axes on any given treatment session. Now, as I mentioned, I think the dosimetry of the device really is quite special, and it is brachytherapy in the good sense in that it generates a gradient dose. I think there's some misperception that there's a highly uniform dose at depth with AccuBoost. That's really not true. So if we look at this cumulative dose distribution in the breast and take a cut through the cross-section of the middle and look at the depth dose profile, what we see is a volcano-like distribution of dose, such that at depth, where we prescribe to 100% in the center, and then that dose rises as we move to the periphery. And the pink shaded area here is the physical confines of the applicator itself, the physical delineation of the applicator. And you will see that the peak dose is actually just beyond the applicator edge. And we see this as an advantage in many circumstances, where we can treat beyond the applicator edge out to about 5 to 7 millimeters, depending upon the applicator size. But we see this, we incorporate this in our actual clinical applications, looking at this specific dose profile. So again, this is a different delineation of that. You'll see with the cumulative dose distribution, the peak dose is actually extending a few millimeters beyond the physical edges of the applicators themselves. So why we got interested in this now over 10 years ago really related to some of the concerns we had about partial breast radiotherapy, be that boost radiation or partial breast radiation as monotherapy, in delivering the dose to the residual tumor. Much of our targeting historically has been looking at an excision cavity, but that does not always represent where the residual tumor is in the breast. So we were looking at systems, perhaps how we could better address that and better target where the radiation dose would go. And looking first at booster radiation, historically, how that target was defined was a variety of different techniques in contemporary practice, very much CT-based. And for booster radiation, the dominant modality used was with electrons, with on-phosphor electrons. And we saw limitations with electrons related particularly to the dosimetry of a very broad beam penumbra and bowing in of the target isodose line at depth, which required that had to be taken into account with the volume of breast tissue that was encompassed with an electron boost. But one of the biggest concerns I've had for many years related to the use of a CT platform to define a target in the breast. Because as I spoke to my colleagues who are breast imagers, they would say one of the worst ways to evaluate the breast is with CT as an image guidance platform. And I think for anyone listening to this in their own experience, when we look at a high-resolution CT scan of the breast, it's often very, very difficult to tell with accuracy where is the tumor bed by CT definition. And there's a bit of guesswork involved in terms of that definition. And I think this is beautifully demonstrated now, also about 10 years ago, with a group from my colleagues from Harvard, where they looked at some cases of a defined, what they just characterized as an easy case versus a difficult case in defining tumor bed. And these were 4 expert breast radiation oncologists doing the target delineation. And for both the easy case as well as the hard case, there was a great deal of disparity in what the target volume was that was delineated based on CT. And we all know that boost volume matters, at least for toxicity. And I think we've all accepted that there is some uncertainty entailed with CT-defined tumor bed delineation, as well as the uncertainty associated with a broad penumbra for an electron beam. So I think the practice for a lot of radiation oncologists is to overestimate that volume and to go big in defining that target volume. But I think we are all aware that that potentially has a cost associated with it. And when we look at the randomized trials that look at the value of boost, clearly a value in terms of the decreasing local failure rates, but at the cost of increased normal tissue complications as reflected in fibrosis. And this is just a case where a very large volume of the lateral portion of the breast boosted the high dose and very robust fibrosis in this area. So AccuBoost gives us the opportunity to minimize the volume of a normal breast being irradiated, both by virtue of breast compression and breast immobilization that we can take advantage of in our targeting. And when we've looked at this, doing 3-dimensional analyses of the volume of breast tissue exposed to radiation with AccuBoost versus electrons, we find that with the same degree of target coverage, the PTV that is defined by AccuBoost is about a third lower than that with electrons. That's all related to the physical properties of the beam itself. And when we also look at the skin dose with AccuBoost, substantially lower than that seen with electrons, and not, not surprisingly, lung and chest wall dose reduced as well. Excuse me. So, as we have looked at this in clinical results, we've done a comparison of outcome with electrons versus AccuBoost, and we find that these dosimetric projections translate into clinical results with reduced both acute and late skin and subcutaneous toxicity associated with AccuBoost that really is quite profound. But we've also gone on to say, again, coming back to this question, what is the real volume that we need to treat when we're doing partial breast irradiation? Excuse me, can we be more guided in the process related to where we direct a radiation dose based on specimen orientation, identifying where the margin is at risk, and hopefully treating only that tissue that's at particular risk. And as I'm sure is the practice in your own institution, surgeons these days and pathologists go to great lengths when they do a lumpectomy specimen to orient the specimen, identify where the tumor abnormality is in the specimen, inking the specimen, and quantifying where the proximity of margin is. And for surgeons, they use this data to do guided re-excisions only to that tissue that's at particular risk. Excuse me. And this concept, of course, has been explored more, I think, in more depth in Europe than it has in the United States. This is, again, almost 10 years ago, a paper from the Netherlands that looked at this concept of when we have a tumor, the area that is most at risk is this rim of about 1.5 centimeters normal tissue surrounding the mammographic or clinical abnormality. But the hypothetical resection specimen is often eccentric with the tumor located just in the periphery of a mass of tissue that's excised. But we guide the radiation boost very much based on that excision cavity, when in fact the volume at risk is really quite small. So can we be more intelligent in the way that we guide a boost dose? So we've taken that concept with AccuBoost, and here is a case of a situation where a tumor bed is sitting down close to the pectoralis fascia, with the CTV being less than a centimeter away from the pectoralis fascia. But when we look at the actual gross tumor specimen, the deepest extent of tumor is at least 2 centimeters away from the pectoralis fascia, and it's only the anterior margin that is close. So you'll see we've placed the applicator here fairly tight on the deep end of the defined excision cavity, and more liberally treating the anterior portion of that volume. And the beauty of AccuBoost is we can take not only that specimen information, but also the preoperative mammogram, and use the preoperative mammogram as a guide along with the pathology information in terms of where the optimal position of the applicator may be. Excuse me. Now, with respect to partial breast irradiation, in our own group, we've had concern about 3D conformal external beam radiation. Excuse me. Even though this is very convenient and non-invasive and a very popular way to do APBI, it's not brachytherapy in the sense that certainly much more in the way of normal breast volume is exposed to high-dose radiation than is achieved with brachytherapy techniques. In our own experience, as we looked at 3D conformal radiation for APBI, we were very concerned about the degree of fibrosis that we saw in this patient population and less than optimal cosmetic outcome. Excuse me, and these results were nicely paralleled with the results from the Canadian RAPID trial. And this is just an example of one of these patients after 3D conformal radiation. In our own analysis, and again, the group, the RAPID group saw the same thing, this suboptimal outcome was very much related, not surprisingly, to the volume of breast tissue exposed to high dose. So once again, as we did three-dimensional modeling studies of AccuBoost as compared to 3D conformal APBI, the median for the same degree of target coverage, the median PTV was dramatically lower with AccuBoost as compared to 3D conformal. And just graphically, coming back to that same plot, if we look at normal breast exposure with 3D conformal as compared to either intracavitary or multicatheter brachytherapy, excuse me, AccuBoost falls much closer to the brachytherapy dose volume relationship to normal breast than it does to 3D conformal. So with that, we initiated a prospective trial of AccuBoost for partial breast irradiation. We did it initially with 34 gray and 10 fractions, and treatment could be delivered either once daily or twice daily based on the patient preference. And the results are shown here, at least with respect to toxicity. We had most patients, if they had any toxicity, it was grade 1. This is some mild erythema you'll see over the skin here and temporary. A small number of patients with grade 2 with some more prominent hyperpigmentation, but no patients developed grade 3 skin reaction or moist desquamation. Excuse me, and we found that the rate of the grade 2 toxicity was very related to applicator type, which I'll explain more in a second, and the separation of the mammographic plates on the breast, which of course will determine the degree of dose inhomogeneity with this sort of source. So coming back to this issue of applicator type, when we began with AccuBoost, we started with this first generation, basically hollow applicator, a very simple cylindrical applicator, but introduced several years ago these newer applicators with these conical inserts really designed for skin sparing. And the conical insert, that's a tungsten conical insert, basically does not affect the depth dose in the breast, but markedly reduces the amount of radiation to the skin, really dramatically reduces it. So when we look at the relative dose to the skin with the conical insert applicator, and there are two different types. One is a skin dose optimized, and the other is a dose rate optimized. But with the skin dose optimized, it really dramatically reduces skin dose. And when we reanalyzed the data according to applicator type, it was using the either mixed of first and second generation or only the second and third generation applicators really determined toxicity, with zero skin toxicity seen in the second and third generation applicators. This we found really very, very impressive in our experience. So with that initial trial, which has been reported, the result so far has been pretty good. We had one elsewhere failure in the population, and 3 patients did develop contralateral breast primaries. And interestingly, all 3 patients elected to have AccuBoost APBI for treatment on the contralateral side. I think that's an indicator of how the patient acceptance of this technique is really quite high. No grade 3 or higher toxicity, and really very acceptable cosmetic outcome. This is just an example of a patient treated on this study. You see her pretreatment with this is a right breast periareolar primary. At the end of treatment, you see a little erythema here. This was right after she had been released from compression, so I think this is more related to the breast compression, the erythema, than the radiation treatment itself. This is at 2 weeks, which is about the peak of the toxicity we would see in most patients. And you'll see just in the upper outer quadrant here, a little erythema associated where the applicator was positioned. But that's pretty much the extent of it. And here she is at 18 months, very little in the way of skin changes. And this is her at 5 years. Overall, I think a very satisfying cosmetic outcome. So with that, we began to look at whether or not we could accelerate treatment as has been occurring with whole breast radiation and in some contexts with other forms of partial breast radiation. One thing we found in our initial trial was that over 3/4 of our patients elected for once daily treatment. They really didn't like BID, so we've really done away with BID completely. However, this resulted in a treatment delivered over 2 weeks, and we wanted to see if we can make this more palatable to patients. So we looked at a 5-fraction trial, really building off the UK FAST trial with a dose of 28.5 gray at 570 centigrade per fraction. And all 40 patients completed this trial with now the median follow-up about 42 months. Pretty typical APBI population, relatively small tumors, all node negative. Excuse me. And the results with this trial, because of the larger fraction size, we did see a little bit more in the way of skin toxicity, with one patient having grade 3 moist desquamation, no recurrences, and cosmetic outcome generally was pretty favorable. But we did see here that with the larger dose per fraction, both the applicator size and the mean breast separation were really critical variables related to toxicity risk. So we really look at, for this hypofractionation for APBI, to limit the breast separation, the plate separation, to about 7 centimeters, and ideally an applicator size no bigger than about 6, possibly 7 centimeters in treatment. But overall, the cosmetic outcomes have been quite good with this technique. Here's a patient 3 years out with very favorable, and again, it's a right breast that was treated. And this was a pretty typical patient, older patient with large tonic breast that enrolled in this trial. So our conclusions from our FAST trial is that the treatment is well tolerated. Skin toxicity was mild, but a few more patients than what we saw in the initial APBI trial with grade 2 to 3. We continue to follow up to see if this translates into any more pronounced later skin toxicity or subcutaneous toxicity. And we're now very circumspect with respect to this fractionation scheme related to smaller targets and minimal breast separation. But it's now we do offer this off study for a large proportion of our patients. In addition to our own experience, we've had a very robust data registry, user registry that we've maintained both for boost treatment as well as for APBI. We've been very interested in looking at the APBI experience across a variety of institutional settings and practice types. And we now have over 500 patients enrolled in the APBI registry. And the results of the first 220 patients from the APBI registry were presented at ASTRO this year. Tumor control rates very favorable, very comparable to other APBI techniques. And again, the population has been very typical for a APBI population. With respect to dose, in the registry, we saw a lot of early use of 34 gray and 10 fractions. We have recommended that given the dose characteristics of AccuBoost, that dose gradient, it is different than the gradient seen with balloon catheters or interstitial catheters. So we've done fairly extensive radiobiological modeling for that, and we think that the most optimal dose, if 10 fractions are to be given, is that it's 3.6 gray per fraction, not 3.4 gray per fraction. So that is increasingly being used throughout the user community. But we're also seeing a relatively wide adoption of the 5-fraction technique, and I think that's growing in popularity pretty significantly. And as reflected in our experience, most users do a daily treatment, not a BID treatment. So just to give you some sense of our experience, our user experience, I just wanted to show you some sample cases. And first, how do we evaluate patients for AccuBoost, and what is the proportion of patients that we find are candidates for AccuBoost? We, in our own analysis of all breast conservation cases, we find that about 70% of cases are eligible for AccuBoost. Reasons for ineligibility are listed here. Patient discomfort with compression, really very rare that's a problem. Inability to locate the tumor bed, rare. And very posterior tumor bed location that we just can't reach with the applicators, also rare. And then perhaps the most common contraindication or ineligibility factor is a very, very small breast size, making breast compression a challenge. With respect to boost dosing, we recommend that you prescribe the boost dose with AccuBoost as you would if you were prescribing electrons, and that's presumably based on the underlying risk assessment for residual disease, and that can vary from 10 gray up to 16 gray in various users' hands. We began doing 2 gray per fraction for between 5 and 7 fractions when we were doing boost. But given the trend to hypofractionation for breast cancer, we now routinely hypofractionate all of our boosts, both with AccuBoost and without. And our typical boost dose is 2.67 gray given over 3 to 5 fractions. So this is an example of a case, a very simple, straightforward case, a good clip cluster, very easy to see, very easy to target and delineate, and a very straightforward case. Clips are nice, but not always necessary, and this is a feature that we came to appreciate as we gained more experience with the system. Here you see clips are there, but you can also see the post-operative changes pretty well. So as we've gotten more confident in our ability to look at a post-operative mammogram, we do not feel that clips are always necessary. It's always nice to have them, but we do pretty well without them as well. Sometimes clips are present, but the target is difficult to delineate on a CT scan. Here you see clips are here, but seeing really what is the target in the midst of all this parenchymal change in the breast based on the CT, this was a real challenge for this case. But however, we sit her up, we compress her, and it really comes together very nicely. And this is, again, what I think one of the great advantages to AccuBoost, being able to have this mammographic image guidance as opposed to the CT image guidance. I just see as such a huge advantage. Sometimes poor cardiac anatomy. There's a case with a deep-seated tumor bed. As we looked at a boost plan with the electrons, here's the anterior descending coronary artery sitting right underneath this. sort of an excessive dose of radiation as a consequence of boost in addition to the tangential treatment. But we sit her up and compress her and are able to encompass this target quite readily with AccuBoost with virtually zero dose, additional dose to the heart. Sometimes with a peculiar chest wall anatomy, this is a patient with a pectus excavatum, and you see just doing a tangential radiation here, really a very significant volume of lung that would need to be treated. Once again, we sit her up and compress her. We see the tumor quite well, and this was a great case for APBI. Deep tumor bed, this is a situation, again, large breast, deep tumor bed, looked at a variety of different external beam plans here with mini tangents, on fossil electrons. We just weren't able to get there even with a 22 MeV beam. Excuse me, and a combination of both photons and electrons, really a suboptimal boost plan. But once again, we sit her up and compress her, and AccuBoost was really just such a tremendous tool to have in a circumstance like this. And this is her in her left breast, now 35 months out from treatment. Really acceptable cosmetic outcome. One area that I've always had concern about in my career with treating breast cancer is in boosting around the periareolar or subareolar tumor beds. And my experience with electrons in this area has generally not been a happy experience, with appositional electrons resulting often in unacceptable toxicity around the nipple-areolar complex. And you know, not uncommonly in boosting in this area to see a permanently swollen or irritated nipple as a consequence of the boost dose that patients really never forgive you for. So this was an area of interest early on for me, is whether or not AccuBoost might afford some opportunity as an alternative way to boost these patients where we wouldn't quite see some of the sequelae that we saw with electrons. So we did a lot of early Monte Carlo modeling with AccuBoost to see what the dose homogeneity would be, given that we were having fall off or flash the applicator across the skin. The Monte Carlo modeling suggested that this was not really a problem. So we began to treat patients in this fashion, and this is an example of one of these patients, periareolar incision, tumor bed sitting right underneath the nipple. This was very early in our experience with AccuBoost. This was the first generation applicator or targeting system. You see the tumor bed here. And here she is 5 years after boost. And honestly, I've never seen a outcome as good as this with electrons. Really no cosmetic deformity, and a patient that was completely asymptomatic as a consequence of the boost. And this was reflected in our user experience, where this was defined by skin flash, but this was primarily subareolar presentation. And this was not only not a disadvantage, we were seeing that these were the patients having really some of the best cosmetic outcomes and least amount of toxicity reports. So this appears to be an experience that a lot of users have had, and as I talk to users around the country, they will often say that if there's no other indication for AccuBoost than to do subareolar boosting, it's a very worthwhile tool in that regard. A deep clip on the chest wall. Here is, I have several surgeons who, just as a matter of routine, when they do a lumpectomy, they always take the lumpectomy right down to the pectoralis fascia, and will often leave their clips right down on the deep edge of that. So when I look at a patient like this when I do my planning CT, I wonder, you know, is this really going to be an AccuBoost candidate given how close these clips are to the pectoralis fascia? but more times than not, when we sit these patients up and compress them, those clips come off the pectoralis quite nicely, and this is an excellent, turns out to be an excellent case for AccuBoost. So my guidance to folks who are using AccuBoost is don't always rely on that planning CT to determine eligibility. The only way you're really going to know is to compress a patient and take an image. And sometimes it could be as simple as when you have a clip or a tumor bed that defined by clips that seems to be just too deep and just coming off the film, and you really can't get an applicator in position in an appropriate way. All we do is slightly reposition, re-angle the gantry by a couple of degrees, and we can often get this to target very nicely. Another area that we've come to appreciate the value of AccuBoost has been in the setting of oncoplastic reconstruction, and we see a lot of that in our practice here. Our breast surgeons, and I think this is a great advantage for patients, the cosmetic outcomes are much better with these oncoplastic techniques. But it can be a nightmare for radiation oncologists to define where is the tumor bed after all this rearrangement of our breast tissue after this type of procedure. So what we have found is, oftentimes in a planning CT scan, we're seeing after an oncoplastic reconstruction, clips scattered all over the place. The surgeons have tried to do their best to reconstruct where the tumor bed was with these clips, but in the supine position doesn't help us a whole lot. But more often than not, again, we compress these patients, and the tumor bed really comes together quite nicely. So this is, again, another circumstance where we see AccuBoost as having a potentially real advantage. And we're in the midst right now of working with our surgeons, and one of our next generation protocols is to see whether or not we might use AccuBoost as a preoperative boost in these patients who are planned for an oncoplastic reconstruction, really to minimize the volume of breast tissue being irradiated. So the surgeons are very interested in that, and we hope to have a protocol active in this regard later this year. For APBI or boost in the setting of breast augmentation or implant reconstruction, this is often a challenge to do where, I think APBI is often desirable in appropriate patients with reconstruction, just to minimize the amount of breast tissue being irradiated and hopefully lessen the risk of capsular fibrosis. And what we find with AccuBoost, it really works quite well, because with compression you can push the implant off to the side often, and this allows for a very nice way to do APBI without the risk of putting catheters next to the implant. Now, what are the cases where AccuBoost just doesn't work that well? Well, there are certainly a few circumstances where that's true. And they relate mostly to having an extreme peripheral location of the tumor bed. And this is an example here in the extreme inframammary fold, and there's a lot of tethering in this circumstance of the tumor bed to the underlying pectoralis fascia. Really just very difficult to get orthogonal compression done in this position. And although electrons are not ideal, it just was a better way to go in a patient like this. Also, again, in the extreme upper inner quadrant, this can be a real challenge to get orthogonal compression and views in this area and get the treatment applicators appropriately positioned. So this is a circumstance that often is best served by electrons. And both the tumor bed location and breast size can thwart reasonable breast compression. In here is a relatively small breast with a tumor bed location down near the inframammary fold, and again, some tethering to the pectoralis fascia just makes it very, very difficult to compress to this location. And likewise, very small breast, but the extreme upper outer quadrant tumor bed location, again, probably best served by electrons. So with that, I will take questions.
Dr. Wazer, thank you so much for that presentation. For anyone that does have a question, please feel free to chime in. I do have a couple that have come in via the chat box. One of them, Dr. Wazer, is with regard to hyperfractionated boost. Mm-hmm. You showed some results with standard boost, but can you comment on your experiences with hypofractionated boost?
Yeah, great question. And we do have a paper that we've published on this, really we're seeing excellent results with hypofractionation. We do hyperfractionation not only with AccuBoost, but when we do electrons now, or even if we do compressed photons, we'll hypofractionate. Our cosmetic results and toxicity results are so far very favorable.
Okay. Next question I have, it's been a long time since I've read mammographic images. How difficult is it for a radiation oncologist to come up to speed on targeting from the mammo image?
Yeah, great question. And fortunately, we don't have to pick up much in the way of subtle changes on the mammogram. What you'll find is the post-op changes really do stand out in most patients quite prominently. And again, if you have clips defining that tumor bed, it's very, very easy to see. That said, there is a learning curve with this, and it took a good dozen cases for us to feel confident in terms of what we were looking at with the mammogram. We would often take some of those early images up to look at with our breast imagers, and just to build our confidence level that what we were identifying as tumor bed was something that they would call the same way. So it's less difficult than you would think, but there is a learning curve. I'll say that for sure.
Okay, and question is just asking, how complicated was it to install the equipment and get it operational?
Very straightforward. Really a matter of hours to get it installed and operational. There is some training that you want to have with your therapist to get them comfortable with acquiring the mammographic image guidance, but it goes pretty quickly. I have to say it was not a disruptive process at all.
Okay, wonderful. So I have one more question that's come in via the chat box, but I just wanted to ask if anyone has questions they'd like to pose. Actually, just got a texted question. What dose do you use with augmented breasts?
For our APBI dose is exactly as we would use for non-augmented breast, and likewise for boosting. I'm not familiar with anyone who does anything different with augmented breasts, unless you are.
No, I don't think we've heard of anyone straying away from either the 34 or the 36 gray once or twice daily.
I see a great question that's frequently asked that just got posted. How long is the treatment, and just how long the patient is compressed waiting to be delivered? Great question. When we look at not just our experience, but we're very curious about what the user base experience is with this across a variety of different practice settings. And for boost irradiation, we find that the total procedure if you're doing one axis for that boost, is about 18 minutes. With APBI, because you're doing both axes and it's a higher dose, it can take anywhere from about 30 to 40 minutes. Now, when we do compression with the breast, we make sure that the patient is not uncomfortable. We don't need to do a diagnostic mammogram, which requires a lot of compression. All we need is image guidance, and we don't need to compress to the point of pain. As a consequence, most patients really find this quite tolerable.
Actually, one thing I would offer as a seeded question of sorts, when we talk to centers, they all have different approaches on how they introduce the technology to patients. Specifically, women coming in have certain perceptions of mammography as being painful. How do you get them to understand that's not the case and that the compression is much less?
Well, we explain the principles behind why we're using mammographic image guidance, just to be more precise and more targeted in how we're doing the radiation. We also tell them that we don't want to cause discomfort, so we will compress the breast to the point where they are experiencing discomfort, and then we'll back off. And we'll ask them to be their own guide to us as to what's comfortable and what's not comfortable. So, having the patient as part of the process here, I think, makes it very acceptable for patients, and as they understand the process, they really see the value of it.
Wonderful. So, for any of the attendees that are out there, if you want to unmute, feel free to go ahead and ask a question of Dr. Wazer directly. We have, I think, still 24 people or so online. We have a new one that just came in, Dr. Wazer. What type of training is available? I believe the therapists in your center are of the opinion it is a painful process for patients. Perhaps retraining is possible for clinical staff.
I'm not sure I understand the question. Related to the training for new users?
I'm not quite sure. I was just reading it verbatim.
Yep. I would say from a training perspective, I actually have to kick that back to you, Ray. You folks really take charge of the training, and I think you do a pretty good job with it.
Well, yeah, I guess the comment I would offer is we have resources here. Jennifer Perkins, our National Accounts VP, also has a strong clinical background, and she will visit centers on a regular basis to provide additional training over time. And I think, as we all know, there's a lot of turnover within the treatment centers. So if you have new therapists, physicists, or radiation oncologists on board, we will come out and provide additional training directly, so it doesn't have to be done by word of mouth. So we have a question. Are you willing to share your slides with participants?
Absolutely.
Okay. Yeah, for all those that are still with us, we will convert this presentation to something that can be viewed online, and we'll share that link with you. And for those that are interested, you can just communicate with me, provide your email address, and we can send you a copy of the presentation. But as we're now just about an hour in, I would like to thank Dr. Wazer for his time and a wonderful presentation. And certainly, if anyone has follow-up questions, we're glad to either field those or to arrange to run them by Dr. Wazer. So I'd like to thank everyone for your time. And again, Dr. Wazer, thank you for this wonderful presentation.
My pleasure.
All
Bye-bye.
right. Have a good day. Bye-bye.